Workman's ischemic contracture. The Workman's ischemic contracture is a permanent flexion deformity of the hands and fingers. This is caused because of the muscle necrosis that happens. Muscle necrosis followed by fibrosis and contracture because of untreated compartment syndrome. It is also called as the VIC. It is Workman's ischemic contracture. Now, talking about etiology, so the causes for this are the supracondylar fracture of the humerus. This is the most common cause where the brachial artery injury happens and there is a compromise to the blood supply. Then forearm bone fractures are at highest risk for compartment syndrome. So compartment syndrome, the risk is more in the forearm bone fractures or in the leg fractures. Crush injuries. In the crush injuries, there is a direct damage to the muscles. And in tight plaster, cast or bandages, they will lead to increased compartment pressure. Similarly, arterial injury and a prolonged tourniquet use. Pathophysiology of the Workman's ischemic contracture is given by Eaton and Green cycle. So this is injury that will lead to swelling, hematoma formation and edema that will lead to increased compartment pressure. Then further there will lead to compromised blood supply that will lead to further muscle ischemia, nerve ischemia, further swelling will happen, and that is a vicious cycle that continues. If it is treated for 6 to 8 hours, then there is a irreversible muscle necrosis. So now this Workman's ischemic contracture is divided into 3 stages. Stage 1 is called as the impending, stage 2 is early established, and stage 3 is late established. So stage 1 is from 0 to 24 hours or up to 1 day. Then stage 2 is from 1 to 2 days, and the stage 3 is for weeks to months. So the stage 1, there is going to be severe pain out of proportion. Then the signs of compartment syndrome, so that is pain, pallor, paresthesia, that is tingling sensation and the paralysis. Apart from that, there is a pain on the passive stretch that is seen. Then in the stage 2 is where the muscle necrosis happens. So muscle necrosis happens because of nerve ischemia. There is a decrease in the pain, but however the swelling is still present. In stage 3 is where the fibrosis and contracture takes place, because of which the fixed flexion deformity happens, or the classical deformity of VIC. So what is the classic deformity of VIC? The classical deformity of the VIC is there is a flexion at the wrist joint, and there is extension at metacarpophalangeal joints, and flexion at the level of interphalangeal joints. So when we talk about a thumb, it is adducted and it is flexed at the interphalangeal joint. So the appearance is called as the claw hand, but it's different from the claw hand due to medial nerve palsy or the ulnar nerve palsy. Now talking about the clinical features, so in the early signs, obviously, there will be signs of compartment syndrome, so pain, pallor, paresthesia, paralysis, right? Similarly, pulselessness will be present. Then the late signs is where the established contracture takes place. So there is a fixed deformity that is formed, with muscle wasting can be seen, skin is shiny, nails are brittle, and the function of the hand is severely impaired. Differential diagnosis for this condition is ulnar nerve palsy, medial nerve palsy, then ischemic contracture of the intrinsic muscles of the hand, and myositis ossificans. Then management for this is very important. This is the prevention. So if the compartment pressure is more than 30 mm, you have to prevent the compartment syndrome from proceeding into VIC, right? Then you have to prevent the use of tight bands. Prompt fasciotomy should be done. So what is the acute stage management? If the VIC has happened, then acute stage management is all the constricting bands or tight bands, they should be removed. Again, go for emergency surgical decompression by fasciotomy, limb elevation, and explore the artery. If it is going to be a late stage, that is where the established contracture has taken place, so in that particular case you have to use a Workman's splint, because now there is a fixed deformity that happens. So Workman's splint is used, and physiotherapy should be done. Apart from that, we can use a certain operative procedure that is called as a max page operation. Max page muscle slide operation, it is done at the level of the medial condyle, so that all the flexor muscles, they are released. Apart from that, tendon transfers, nerve decompression or arthrodesis, that is fixed joint deformity, can be done. So this is all about the Workman's ischemic contracture. After that, the next important topic is the supracondylar fracture of the humerus. So supracondylar fracture of the humerus, it happens at the distal end of the humerus above the condyles and involves the metaphysis. This is most common in case of children, and it is seen in fall in the outstretched hand or the foci injury. Now talking about the anatomy of the distal humerus, it consists of it is flattened anteroposteriorly, there is anteriorly there is coronal fossa, posteriorly there is auricular fossa. It is a weak part, and because of which it is more prone to fractures. It is related to the brachial artery, and because of which supracondylar fracture is associated with compartment syndrome or VIC. Then associated with median nerve, radial and ulnar nerve as well. It's the most common elbow fracture in case of children, and it is around 5 to 10 years in children. Now why it is 5 to 10 years in children? Because this reason is given over here. because in this particular age the bone is actively remodeling. There's a laxity of the ligaments because of which actually hyperextension is possible. Then the next is cross section. Cross section, it is less cylindrical and more of an elliptical, and metaphysis consists of the purinoid and olecranon fossa, which is weak. Now, the displacement that happens in supracondylar fracture of the humerus, it is given by this mnemonic, that is DIM. So there is a dorsal impact and a medial tilt that happens. Now there are two types, that is extension and a flexion type, out of which 95% is the flexion type. In that 60% is the posterior medial type, and for rest is the posterior lateral. So posterior medial displacement, it is going to affect your median, is going to affect the radial nerve, while the posterior lateral displacement is going to affect the anterior interosseous nerve, which is a branch of median nerve. So this is very important, but the most common nerve injury is the anterior interosseous nerve, or it is going to be a median nerve that is most commonly involved in the supracondylar fracture of humerus and not the radius nerve. The classification for supracondylar fracture is the Cartland's classification. So there are three types. So type 1 is when there is a hairline fracture, the cortex is still intact. In the second, there is going to be a posterior cortex that is intact, and Cartland type 3, there is complete fracture along with displacement. The other clinical features, there is a S-shaped deformity of the hand that can be seen, and dimple sign, that is puckering over here, it can be seen. The three bony prominences that are maintained in supracondylar fracture of humerus, they are not maintained in case of elbow dislocation. X-ray sign, the X-ray sign, there is anterior pad of fat sign, posterior pad of fat sign, then there is a teardrop sign which is disturbed, right? Then the crescent sign, which can be seen, and fishtail sign is also seen because of the proximal fragment it gets serrated. Now what is the management? So management, it has a long arm cast 60 to 110 degree for immobilization, where the triceps acts as a natural splint. And for type 2 and 3, for type 2 it is closed reduction with K-wire and open reduction with K-wire, but however it mostly depends upon whether the radial pulses because of brachial arteries or pulses are they felt or not. So there is a whole management algorithm that we will talk about. Then post-treatment, there is a swelling. For that, Dunlop traction, which is skin traction, and skeletal traction, assessment traction that is used. Post-reduction, the X-ray assessment is done by Bowman's angle. So in normal, the Bowman's angle should be less than 60 degree. It talks about the varus tilt, and for posterior tilt, to talk about the teardrop sign. Now, so this is the whole management algorithm for the supracondylar fracture of the humerus. If there is a radial pulse that is present and the fracture is undisplaced, it is type 1, then in that particular case we go for a POP slab, right? A long arm slab 60 to 110 degree, and it should be applied for 3 weeks. If the radial pulse is present and the fracture is displaced, that is type 2 or 3, then close reduction with K-wire fixation that is done, and it is done under the image intensifier. Reassess it after 1 week. If it is normally present, then you have to apply the POP support for 3 weeks. Now if there is no image intensifier, in that particular case you have to do close reduction with K-wire fixation under general anesthesia. Now check it after checking on the X-ray after 1 week. If the reduction is maintained and it is satisfactory, then in that case continue with the POP aspect. If the reduction slips or from the chest X-ray it is unacceptable reduction, then in that particular case you have to go open reduction with the K-wire fixation. If the radial pulse is absent, then you have to maintain the you don't have to put a slab over here, cast over here, because if you put a POP cast over here, then that can lead to compartment syndrome. So put a slab and maintain the position in slab position for 48 hours and check for the return of the pulses. If the return the pulses happen in 1 hour, then you have to go for proper reduction and close reduction with K-wire fixation. If the pulses do not appear and the capillary circulation is good, then you have to keep the slab under observation for 48 hours. If the pulses are felt, then go with the procedure, that is close reduction with K-wire fixation, if followed by POP slab. If the pulses don't appear even after 1 hour, or if the capillary circulation is poor, then in that particular case you have to do open reduction, explore the brachial artery and fix the fracture. What are the complications of supracondylar fracture? The complication most common is going to be the malunion. Then apart from that, there is a pubitus varus deformity that leads to Gurn stalk deformity. So there is a posterior medial displacement, but however it is non-progressive stable deformity, and the management for this is the osteotomy. So there is a King's osteotomy or French osteotomy. French osteotomy is better as compared to King's osteotomy, which is lateral wedge osteotomy. Normal carrying angle, remember, it is for males it is about 10 degree and for females it is 15 degree. Then Mattau's sign is seen. What is Mattau's sign? Mattau's sign means there is a myosite is opposite to consent, because of which this median now it gets pressed in between. Apart from that, other complications that is Volkmann's ischemic contracture or compartment syndrome can happen in supracondylar fracture of females. Then there is a Monteja's fracture. So in the Monteja's fracture is also called as a fracture of necessity, or it is also called as a treacherous fracture. It is a fracture of the proximal one-third of the ulna along with the radial head subluxation. The mechanism of injury is going to be FUSH and is common in children. The classification, treacherous body. So remember, Bordeaux's classification is used. So the class 1 is going to be anterior subluxation along with anterior angulation. It is also called as extension type and is seen in FUSH. Class 2 is flexion type. It is seen when the arm is flexed and the person falls. Here there is a posterior subluxation of the radial head along with posterior angulation. In the class 3 there is a lateral subluxation of the radial head, and that is lateral. And in class 4 there is anterior subluxation of the radial head along with the proximal fracture of radius as well as ulna. Now the class 1 it is extension type. It is more common in case of children, while more common in case of adults is a class 2, that is the flexion type. Then most common nerve injured is going to be in Monteja's fracture is the posterior interosseous nerve, and because of which it will lead to finger drop and the thumb drop and not the wrist drop. The X-ray rule, so that we cannot get cheated, is the McLaurin's line. So this McLaurin's line is the line which straight away cuts from the shaft of radius. It cuts the capitulum at any point. If it does not, then there is Monteja's fracture, treacherous fracture. Now, notice the management. In case of children, the management is close reduction, while in adults, children less than 12 years, it is above the elbow cast is used, and for unstable children, intramedullary KY it is used. In adults, it is open reduction with plate and screws. So now the position application of this POP cast, so above elbow cast is used. Here, if it is a fracture in the proximal third of the ulna, then supinated position. If it is there in the middle third of the ulna, then a mid prone position. In the distal third of the ulna, then there is going to be complete prone position where the POP cast will be applied. Then complications. So complications will be a unreduced radial head subluxation, and that can lead to stiffness of the arthritis over there. Non-linear or non-linear can happen, and if fusion of the radius and ulna can happen, that will lead to radial synostosis. Now very important is more common in type 4, where there are both the fractures that happen. Similarly in type 4 we cannot do closed reduction, so here open reduction with plate is used. Next, a very important fracture, that is the Colles fracture. So when we talk about a Colles fracture, it is the mechanism of injury is going to be the FUSH, and here it happens at it is not just a fracture, it is a fracture dislocation to rest radial nerve joint. It is extra-articular in nature. It is more common in elderly population, more than 40, more common in females because of osteoporotic bone, and very important, happens at the corticocancellous junction, right? Then the displacements that are seen, displacement by pneumonic, that is called as this DILS. So D stands for dorsal tilt and the dorsal displacement. I stands for the impaction, L stands for the lateral displacement, lateral tilt, and S stands for supination. So these are the displacements. Clinical features, obviously it will come with pain, swelling, tenderness, and a dinner fork deformity will be present. Now the radiology. This is the most displacement that can be identified on the X-ray. Lateral displacement is seen on the AP view. Complications. So most common complication is the stiffness of the fingers, right? Then after that, malunion, subluxation of the radial nerve joint can take place. Carpal tunnel syndrome, Sudeck's dystrophy is present, and apart from that, the rupture of extensor pollicis brevis and abrupt extensor pollicis longus tendon can happen. Extensor carpi radialis brevis and extensor pollicis longus tendon takes place. Management is going to be, if it's an displaced fracture, we have to immobilize it with the help of Colles cast for 6 weeks. If it is a displaced one, then we have to first manually reduce it and then immobilize with Colles cast. Now what is the technique? The muscles of the forearm should be relaxed. The surgeon should first give a traction, then there should be a pronation, then there is a wrist flexion and ulnar deviation. So in this way the POP cast is applied. Now this is a below elbow POP cast, so we start applying from below the elbow and go up to the metacarpophalangeal joint. It is applied in a cotton lotus position, French kiss position, or hand kiss position, and the patient is encouraged to move the fingers as the plaster dries, and X-ray should be taken to see whether it is satisfactory or not. and you have to maintain this POP cast for at least 3 weeks. Then another is the Smith fracture. The Smith fracture is called as reverse Pulleys fracture. It is a garden spade deformity. Again, there is a push injury with uh, pronated arm and palmar flexed. There is a ventral displacement or a tilt of index place. Then other fractures that happen around the wrist joint consist of the Galeazzi fracture. So the Galeazzi fracture is the fracture of the lower third of the radius along with distal radial nerve joint dislocation, also called as Speedman's fracture, fracture of necessity because surgery is required in almost all the cases, also called as the reverse Montegia's fracture. Clinical features: the radial striated process it is prominent and because of which piano key sign is seen. And management, as I said, always open reduction is required with plates and screws. In Galeazzi's fracture, the most common nerve that is involved is the ulnar nerve palsy, or followed by anterior atrocious nerve palsy. And the tendon that is involved is the extensor carpi ulnaris tendon. There is something called as Essex Lopresti fracture. Essex Lopresti fracture is a combination of Monteggia and the Galeazzi. So there is going to be radial head subluxation along with distal radial ulnar joint dislocation. The most reliable size is the wrist pin. Lateral view is X-ray view is taken. For radial head, it is replaced by stylistic prosthesis, and mere excision should not be done because that will lead to proximal migration. And then talking about the styloid fracture, so radial styloid fracture is called as the Schoffer's fracture, Backfire fracture, or the Hutchinson fracture. It is done by close reduction internal fixation with below elbow POP cast. Then Barton's fracture. Barton's fracture is the intra-articular fracture of the distal radius. The types are volar Barton and dorsal Barton, out of which the volar Barton is more common. This leads to displacement of the carpal bones. For volar Barton, we use the open reduction internal fixation with anterior buttress plating, while the less common one, that is dorsal Barton, we go for close reduction with above elbow POP cast. Next is the Bennett's fracture. The Bennett's fracture is the oblique intra-articular fracture of the base of thumb. It involves the metacarpophalangeal joint as well. This is caused because of the fist fight, that is fighter's fracture, and there is going to be distal fragment. It is attached to the abductor pollicis longus tendon, and abductor pollicis longus tendon is going to get affected because of it. Then there is something called a trigger finger that is caused because of stenosic arthritis that affects the A1 pulley. Box's fracture is the fracture of the neck of the fifth metacarpal, and the POP is applied in its extra-articular fracture where the POP is applied in James position. Rolando's fracture. Rolando's fracture is the comminuted fracture of the base of the first metacarpal. Here, management is open reduction internal fixation with the mini screw. Then Terry Thomas sign is because of the fracture of scaphoidal ligament. Jersey finger is because of the hyperextension injury wherein the flexor dorsitarum profundus is damaged. Mallet finger, also known as the baseball finger or the drop finger. Here this is injury to the extensor tendon of the distal phalanx, and that is the middle slip is getting affected. This is generally seen in nurses when they tuck the blanket under the mattress. So here the management is using a mallet finger splint or a Smiley's cast for 8 weeks, or the operation can be Fowler's central slit denotrum. And the scaphoid fracture. Scaphoid fracture is a common fracture that is seen in young adults. Here very important, the scaphoid bone is a bone that is located in the both proximal and distal rows of the carpal bones and does not articulate with ulna. It forms a radial wrist joint. Then blood supplies by the radial artery. The most common site that is affected is the waist of scaphoid, where the blood supply is less, and more chances of avascular necrosis. However, they are present at the proximal side of the scaphoid bone. Push injury is common, and clinical features will be pain and tenderness over the scaphoid bone, as well as a deformity that is called as humpback deformity. Clinical test is a scaphoid lift test and a Watson's test, where we move the hand from ulnar to radial side that will provocate the pain. And the view of choice is the oblique view or the scaphoid view. The cast is put for 6 to 10 weeks, and the management will. So on this fracture, then we put the cast for 6 to 10 weeks in a glass holding position. So this is the glass holding position, and the cast name is called as the Bowler Gauntlet cast. Then in the displaced fractures, it is done by open reduction fixation with Herbert screw. If it's a displaced cast, it is a headless screw. And the complication, most common complication is non-union followed by avascular necrosis, that is called as the Prezia's disease. Then the next is the shoulder dislocation. So before the shoulder dislocation, we should talk about anatomy. That is, it's a ball and socket joint. Then the rotator cuff muscles, which is located anteriorly, which is located posteriorly, supraspinatus located superiorly, and inferiorly is the weakest one. But talking about the shoulder dislocation most commonly happens in the anterior dislocation of the shoulder, and there are many types like preglenoids, subclavicular or subcoracoid. Of which the subcoracoid type is the most common type. It is associated with clinical features of abduction and external rotation. Posterior dislocation, it is ADIR, and in case of inferior dislocation, there is a hyperabduction that is seen and loss of round contour that is called as the luxatio erecta. Then the tests that are used are the Dugas test, wherein the patient is not able to touch the opposite shoulder. Coloris test, where the circumference of the axilla lengthens. Then for the Brand's test, anterior axillary fold it falls down, and Hamilton-Ruller test. Generally, the lateral condylate humerus and acromion procedure do not touch with the ruler, but in case of dislocation, they do touch. For posterior dislocation, the characteristics lines like the bulb sign, light bulb sign, and the vacant glenoid can be seen. Similarly, reverse Bankhart's lesion and the Hilsack lesion is seen. It is associated with electroconvulsive therapy in seizures. However, the anterior dislocation, what are the excess signs? There is a Bankhart's lesion. Remember the mnemonic Y, so it happens in the anterior inferior region, in between the glenoid labrum and the capsule. Then the Hilsack's lesion. The Hilsack's lesion, it appears as posterolateral and also called as a Hatcher's deformity. Now, the terrible triad is the Bankhart's lesion, then the Hilsack's lesion, and the anterior glenoid trail getting narrowed. It will lead to recurrence of the shoulder dislocation. What is the management? Management is going to be conservative by the Cochrane procedure, that is team, that is traction, external rotation, abduction, and adduction and medial rotation. Then there is the Stimpson's gravity method or Hippocrates method. So what is the Hippocrates maneuver? The patient puts the foot on the axilla of the surgeon puts the foot on the axilla of the patient and applies a steady pull to the semi-abducted arm of the patient. Then the surgical management is by Bankhart's operations. It is the most commonly done operation. As I said, in the Bankhart's lesion, it is between the glenoid labrum and the capsule. So here the glenoid labrum and the capsule is reattached. In putty blood operation, then there is a Bristow operation. So the putty blood operation, the subcoracoid muscle is tightened. Then the next is McLaughlin's operation. Apart from that, what are the complications? The most common complication or this complication is the nerve injury to the axillary nerve. Then the artery that is injured is the axillary artery, and the brachial plexus of the posterior cord is damaged. In case of recurrent shoulder dislocations, shoulder replacement is done. So standard shoulder replacement is done by the prosthesis of the head of humerus, while the reverse shoulder displacement is done in rotator cuff injuries, where the ball on glenoid is seen. Next topic is the frozen shoulder. So frozen shoulder is a condition wherein the shoulder joint or the glenohumeral joint, it becomes painful and stiff because of the loss of the resilience of the capsule, and it may be caused because of the adhesions within the capsule. So etiology is unknown, but however the high-risk factors are going to be the diabetes and history of trauma. Clinical features is a pain that worsens at night, and initially the pain is limited to abduction and internal rotation, but later the pain presents all the time and all the movements are severely limited. Management: the disease is usually self-limiting for 6 to 9 months. After that, it won't resolve. So for that, analgesics, hot fermentation, physiotherapy, and intraarticular injection of steroids if required may be given. Then carpal tunnel syndrome. Carpal tunnel syndrome is a compression of the median nerve within the carpal tunnel at the wrist. This is caused because of repetitive movements of the wrist, or postpartum hypothyroidism, diabetes mellitus, or rheumatoid arthritis. Then clinical features: there will be pain, numbness in the lateral 3.5 digits, nocturnal paresthesia, thinner muscle wasting, and weakness of thumb position. Clinical test: Tinel sign. Tinel sign is when you tap on the median nerve, there is a tingling sensation. If this is absent, then that means it is worsening. Allen's test: it is reverse muscular. It produces paresthesia. Then management for this is conservative management by respiratory, NSAIDs, steroids, and surgically we release the carpal tunnel. Then there is a decumbens tenosynovitis. Decumbens tenosynovitis is a stenosine tenosynovitis of the first compartment of the wrist, first dorsal compartment, and it involves the abductor pollicis longus and extensor pollicis brevis. The risk factors: are the repetitive thumb movements, repetitive movements of the wrist, postpartum hypothyroidism, rheumatoid arthritis, right? The clinical feature that is the pain that is present on the radial side of the wrist. The pain is aggravated by thumb movements and tenderness over the radial styloid process. Very important clinical test that is used for eliciting it is the Finkelstein test. So Finkelstein test is where we ask the patient to make a fist with the thumb inside it, and we ask the patient to move towards the radial tip. The wrist is ulnar deviated, and there is a severe pain on the radial styloid, which is a positive Finkelstein test. Management is conservative. The rest and splitting, NSAIDs, local injection is given. Surgically, we can go for release of the first dorsal compartment. And then the next two important topics, that is tenuous elbow and golfer's elbow. Tenuous elbow is lateral epicondylitis, while the golfer's elbow is the medial epicondylitis. Lateral epicondylitis is where the pain and tenderness it is localized to the lateral epicondyle of the humerus, which is a common region for extensor muscles. Pain is aggravated by extensor tendons whenever the wrist is stretched or the fingers are stretched or extended. X-ray reveals no abnormality. Management is analgesics and local injection of hydrocortisone if the tenderness is more. Then medial epicondylitis is again the same pain and tenderness on the medial epicondyle, which is a common origin for flexor muscles. X-ray reveals no abnormality. Management is analgesics for 2 weeks or local injection of hydrocortisone if the tenderness is much more.